All right, so we've got a few minutes past 8, so why don't we go ahead and we'll go ahead and get started here. I know it's getting a little bit later in the east, so why don't we go? So I would like to welcome everybody. Thank you for joining us tonight for our Haag-Streit happy hour. I sure hope that you enjoy this format with some advice from our esteemed panelists tonight. We really thought that a more informal happy hour type approach would be in order. So we encourage any of you, if you've got your drink, please join us. Our intent here was to have a conversation among peers as if we were all sitting together in a bar somewhere. Hopefully we'll be back doing that again sometime soon. So as Dr. Snyder a moment ago mentioned, I'll repeat, please, if you would have any questions, you can use the chat button, which is located down on the bottom ribbon bar or bottom bar of the Zoom window. And we'll take those questions and Lauren will moderate that and get those into our panelists as we go along. So with that, it's my distinct pleasure to introduce our panelists for tonight. Dr. Jonathan Myers is the Director of Glaucoma Service at the Wills Eye Hospital in Philadelphia, where he's been in practice with Dr. Jay Katz now for over 20 years. Dr. Myers has authored and co-authored more than 90 articles in peer-reviewed journals and has lectured internationally regarding the diagnosis and treatment of glaucoma. He serves on the editorial boards of the Journal of Glaucoma and Glaucoma Today. We're very glad that you could join us tonight, Dr. Myers. Dr. Christopher Riemann is a vitreoretinal surgeon at the Cincinnati Eye Institute. He's a vitreoretinal fellowship director at the Cincinnati Eye Institute and University of Cincinnati, and is a volunteer associate professor at the University of Cincinnati School of Medicine. Dr. Riemann's a member of the Clinical Governance Board of the Cincinnati Eye Institute, is the section chief for ophthalmology at Bethesda North Hospital in Cincinnati, and is a member of the board of trustees of the Clovernook Center for the Blind and Visually Impaired. Thank you very much for joining us tonight, Dr. Chris Riemann. And our last panelist, but certainly not our least, Dr. Mike Snyder joins us from the Cincinnati Eye Institute. He has a passion for complex cases, niche implants, and ergonomics, as well as a passion for teaching. He's no stranger to academic meetings, having given hundreds of talks. We are quite happy to have Dr. Michael Snyder join us tonight as well. So without further ado, Chris, how about if I turn it over to you and let you take the conversation away?
That's fabulous. Thank you for the introduction, Garrett, and thanks, Mike and Jonathan, for being here and joining us for this discussion. You know, when we were thinking about how we might be able to add value, as a group, we were thinking about, well, you know, COVID, it's being talked about a lot, but it's really not being discussed in an informal capacity. And I think having an open, honest, transparent and real conversation about COVID makes a lot of sense. You know, these are unprecedented times. We've heard that word a nauseatingly frequent amount of time, with lots of unique challenges. And what we want to do today is talk a little bit about how COVID has impacted our medical practices. And I think it makes sense to start with, Lauren, if you could show slide 2, a little bit of data about what the magnitude of the shutdown has been. So, you know, ophthalmology, if you look at this table here, these are the different subspecialties and what happened with the initial COVID shutdowns and then how we all bounced back. Ophthalmology was hit some of the really hard with the initial shutdowns and when elective surgeries were suspended, and then bounced back pretty quickly. And let's go to the next slide. And you know, the data from our institution here at the Cincinnati Eye Institute, we got hit really hard as well. We beat the benchmarks a little bit, and we bounced back a little bit better than some of the other practices. And we can talk about why perhaps that was. Let's go to the next slide, Lauren, please. But no matter what you look at it, this is our data from CEI and our parent organization, CEI Vision Partners. We do about 42,000 patient encounters every month. That's our baseline here, and you know, these are the new patient visits, and they took a nosedive, a real nosedive. Mike, kind of looking at this data, tell us about the events of towards the middle and end of March and how it impacted your clinic.
Well, we were talking a little bit earlier that I think within ophthalmology, there's actually been a stratification as well, depending on one's practice. My clinic basically went down to 0 because there are very few things that I do that must be done right now. And so when we basically went to shut down except for urgent issues, not too many of the things that I do are urgent. Most of them could be semi-urgent and planned, but most of them can be pushed back a little bit. Whereas I know that you, Chris, were operating certainly at less capacity than usual, but obviously quite a bit more than me. I didn't walk into the office for 8 weeks.
Jonathan, how about you? As a glaucoma, so Mike is cornea cataract, and you're a glaucoma specialist. What did the initial shutdowns mean for you and your patients?
Well, it's funny to look back and realize the things we got right and wrong. Hard to explain why, but at the time I and we thought the shutdown would be like 2 to 3 weeks. So we adopted short-term strategies early on. And then we were only doing emergencies. We were at like 10% of our volume for a while. And so we went on to more comprehensive measures to track cancellations for non-urgent follow-up and keep lists of rescheduled versus pending patients. And actually, we did a lot of extra work because we just didn't realize the scope of how long this would be, and we had to sort of redo our systems. But for a while, we were down at 10% through, I guess, April, May for our practice.
Lauren, can you go to the next slide, please? There we go. So this is a little bit busy, but it stratifies exactly what you're saying, Jonathan. So if you look at our ASC volume, our ambulatory surgery center volume went down to about 10%, and that was mostly retina or retina emergencies, a few endophthalmitises and glaucoma, and obviously retinal detachments. But the interesting thing is, if you look at the green line, injections took a stark hit down to about 60% of baseline volume, but bounced back very quickly in a matter of weeks as we figured out that if patients with AMD don't get their injections, they have a stunning need. They stunningly feel, many of them, they can perceive the visual loss. That's, I think, one of the differences between retina and glaucoma. John, in glaucoma, your patients are going to go blind if they're not treated and if they don't take their eye drops, but they may not know it or perceive it, as opposed to macular degeneration. How did the patients perceive it? How did the glaucoma patients perceive their need to come in?
Yeah, so I think you really hit the nail on the head. It's so indirect and sometimes slow and not appreciated by patients that we have some sad stories of people who just didn't realize that we were still there for them. They ran out of their eye drops. They didn't think they could call to get refills. We were there 24/7 phone and emergency wise. And so, and then there were, of course, people who just felt their risk of COVID was higher and then their risk of going blind from glaucoma by missing a visit, which for a lot of patients is just true. But now there are many patients who haven't been seen for a year. So we're still playing catch up.
Yeah. No, so Mike, how much of your volume is new patients versus working through the backlog of what you've what you missed in the shutdown?
Well, my practice is kind of weird. I don't have a whole lot of chronic people that I take care of because my practice is mostly there's an acute problem that needs to be fixed. I fix the problem, I get them through their post-op time, and they're gone. So after 2 months of being out, my clinic started up a little bit slowly because it was basically only new patients. There was a brief catch up with the post-op people. The 1 week visits ended up happening by phone. They just didn't happen in person. And, we saw everybody for their month visit, and, we just saw more new patients. And then, of course, once the system gets primed, it kind of works its way through. But I don't really have a backlog of patients per se, except from people from out of state. That's actually been a little bit of a challenge, because when the various people coming from distant places, we've been kind of monitoring week to week and month to month as to which areas have huge spikes. We don't want people either traveling through areas of spikes to get here and then showing up in the clinic, or traveling from an area of spike when we're doing, when we were doing pretty well. Right now, Ohio looks pretty crappy, so everybody else looks pretty good. But we've been fairly cautious with having people jump on airplanes to come out here for anything but acute problems that can be delayed and deferred. So there is still some delay and deferral for some of the unusual, complex, out-of-state, distant, airplane away people.
Jonathan, yeah, I'm sure you guys have a bunch of folks that travel in from long distances as well. How did you deal with far away patients?
Yeah, really complicated issues, as Michael was saying. So essentially, because New Jersey next to us was shut down for elective surgeries, there were patients who came to us even with retinal detachments who didn't have other options because their local providers didn't have options. It got very complicated. We tried to be reasonable in terms of balancing the risks of COVID against the risk of the eye disease. We set up a COVID isolation room, which was a single exam room in a separate place with a separate air branch off the main equipment. And so we were able to see people who either had COVID or were just thought to be very high risk in that isolated environment with special protective gear for everybody involved. And so we sort of muddled through, but we maybe were not quite as strategic as trying to think about where people were traveling through, as Dr. Snyder was saying. But indeed, so there were people who got care, and there were people who we got to later that we wish had found a way to get to us sooner.
Yeah, we have the same thing. Jonathan, what about staff? With the shutdown, not all the staff had the number of hours that they needed. How did you deal at Wills with your employees? And there's the clinic employees, there's research trial employees, and then there's OR employees. And these folks are very highly trained individuals with specialty knowledge and skills that aren't really easily replicated. And if you furlough them and send them out the door, who knows if they're coming back? Did you guys have a strategy?
So true. So true. And we were really lucky to have the support of administration on seeing the long haul picture. That, in this case, thinking it was going to be shorter than it was may have allowed us with administration to be a little more bold than maybe they would have, knowing in retrospect. But we, like the rest of America, got creative about what people could do from home. We actually had techs who didn't have as much to do who came in and learned new skills during that time. So some techs who were weak on refraction, how to use the OCT, not as good with the field. We had tech-to-tech training sessions. And then we also used this opportunity to train techs to do appointment scheduling and checkout, because our new workflow, which we'll talk about, involved the techs doing checkout. And so the downtime was actually an opportunity to build up to be ready for what we perceived would be the new workflow. So on that side, we were a little bit lucky with how things worked out in the support. I do go to a private practice a day a week in Delaware, and they did wind up furloughing people, some of whom are back now and some of whom aren't. So very much to your point, there are real pressures in private practice that made it super hard, as everyone knows, super hard.
Yeah. Mike, what about your staff? What did you do with your staff?
Well, we as an institution tried to keep people as busy as we could. Some people did get furloughed. And I can tell you that worried me greatly, because there's a bunch of folks that I work with, especially our research teams. Boy, those folks are a very special, kind of individual, and they're not easy to find, and they're certainly not easy to train, and they're very, very difficult to replace. So at one point, I made sure I was checking in with them at least every couple of days and make sure that they were able to take care of the things that they were needing to take care of. Some felt that they were instructed not to do certain things. I told them do them anyway and keep a log, and I'll make sure that you do okay. So there was a lot of hand-holding going on, and some of it was administrative from the top, and there was a lot of administrative supportive things that our team did, but some of it was at the very personal level. And I think that's these are, as you mentioned, unprecedented times, and sometimes you just need to reach out to your community. And I think that each of our pods, each of our small sub practices are individual microcosms and communities, and in some ways like families.
No doubt about it. We spend more time with, I spend more time with my scribes than I spend with my wife and kids. That's just the reality.
Yeah. Hey, Chris, we did get a question in the chat that I thought was relevant before we maybe move on to other topics.
Sure.
Jonathan quick touched on a part of this question. Someone asked, have any of you treated patients with COVID-19? How so? If so, how was the office flow? Did you keep the patient in a single room? So Jonathan, you kind of mentioned that you did have kind of a COVID room already. Chris and Mike, I wondered if you might just respond on that same question as to how you handled that at Cincinnati Eye Institute.
Well, CEI does have a COVID room identified. I have treated COVID patients. I just don't know who they are.
I agree. It's a universal precaution kind of a thing. So especially now with the numbers spiking in Ohio, in the past 5 working days, I've seen 4 patients who within a day or two after seeing me called up and said, "Oh, by the way, I tested positive for COVID." And that's just a reality, and that's why we mask up, and that's why we have our workflows changed so that we stay more than 6 feet apart for less than 15 minutes with numbers to spare there.
So, Chris, is this a good time to talk about the universal precautions? Because, we all have different ways of doing universal precautions, and I'm fairly risk averse for those who know me, and my universal precautions are probably more extreme than most, if not all. Do you want to jump into that now, or do you want to? Well, here we go. Okay.
I think that's a great thing. So in early June, the numbers were looking a little bit less bad. We got a better handle on the whole COVID thing. At least we thought we did, and the regulatory powers let us go back to work. So, Mike, how long did it take you to ramp back up?
A couple weeks.
Okay.
Really
Jonathan,
straightforward.
Jonathan, and when did clinic and OR restrictions ease in Philly?
It was mid-June, late June, and we had a slower ramp up, I think for 2 reasons. One is our patients were not confident about coming in at first for lots of good reasons. And then that gave us time to practice the new workflow at lower volume. And then because I am, as they say, a bottom feeder, until my referring doctors got back up to speed, obviously the new patients were also slower, although there's a backlog, so it was complicated, but it took a couple of months.
Yeah, and it's interesting for me. So we bounced back pretty quickly, in part because in the OR, if you look at the gray tracing here, we bounced back within 2-3 weeks. We're almost at 100%, and in large part because we didn't furlough any of our operating room staff. We actually set up a Johnny homeowner N95 sort of kind of mask assembly line where there were sewing masks, and we made over 1,000 masks for our team members, and we all got cloth masks that take HEPA inserts, and it was a way to keep them busy and so on and so forth. But for me, I'll tell you, I was about half-time busy during the shutdown as a retina guy, and it was very interesting. I was getting home at 2:00 in the afternoon, and I rather liked that. So for me, I had a personal epiphany You know, I've been in practice now for 21 years, and I was always, it's either Mike or mine or Anoop Katana, who's one of our glaucoma docs, whose cars are always the last ones in the parking lot. And you know, I happen to really love my family and I love my kids, and especially in these times. So during the ramp up, when the ramp up was going on, I told my staff, nobody gets scheduled after 3 p.m. So even if I'm having a lousy day and I'm running 4 hours behind, I'm still home to have dinner with my family at 7 o'clock. So that's a change. My new baseline is probably somewhat lower than my pre-baseline by design on purpose. So now to the interesting part of the discussion. Each of us has adapted to the new COVID reality in ways that most suit our patients, their disease states, our personal fact patterns, and those of our teammates. Universally, most medical practices have a mask mandate. We're keeping family members out of the building and out of exam rooms, except for in very rare circumstances. Most of us are doing temperature checks and COVID questionnaires on anyone entering the building. We've removed seats from the waiting room to keep people 6 feet apart and are reducing building dwell times as much as possible. Jonathan, are you doing anything different at Wills beyond that from the patient flow perspective?
We're doing, I think those are really the important things. Our focus has been on, in general, less time, fewer contacts. So we do pre-registration before they get there by phone. We have a one patient to one tech, one room approach. So patients aren't bouncing between techs and rooms. So the tech grabs the patient and does the testing on the way into the room, takes the patient to the room, and the patient gets checked out from that room too, not at some central checkout desk. And so we have many fewer contacts, and we have a real emphasis on time, because as the song goes, every breath you take, every move you make, you know, every breath increases the risk to the patient and to the patients around them and my staff. So the emphasis on time dwell time is big. Yeah.
Mike, what family members do you let into the building with the patient? What are the circumstances where you'll let folks in?
Well, if we've got people who need physical assistance because of mobility impairments, or if they need mental assistance because of cognitive impairments, those are the people who get in. Somebody who just wants to have an extra set of ears, we let them bring in that set of ears by phone.
That's exactly right. So Mike, you've got a very, very innovative and radical workflow adaptation that I think the audience would be really, really interested in. Tell us about how you see patients now in the realm of COVID.
Well, as Jonathan said, our people are checking in from the parking lot, and doing that, we've actually got software so they can check in on their cell phones through an app, and you know, they're getting interviewed by phone first, and we're trying to make the fewest amount of and volume of, as Jonathan said, breaths that you take in face-to-face setting. And I've kind of taken that to the extreme. And if you told me as an ophthalmologist that I would spend 95% of my day with my butt in a chair staring at 3 computer screens, well, this is what I do now. So this is my kiosk office that's down the hall from my exam rooms, actually across the hall from my exam rooms. And I've got a laptop on the left that actually is logged into a HIPAA compliant telemedicine system called DoxyMe. It's got hookups. I've got my patient charts for my EMR and my patient studies set up on the 2 monitors that you see behind that. And you can see outlined in red, that is my preferred alcohol preparation. So I love Purell, you know, and I know that you guys probably have some really good glasses of wine, but I'll take the Purell any day of the week, right? Because I am at risk averse. Let's go to the next slide, please.
But before we do that, I just want to point out, Jonathan, can you hold up the bottle that you're drinking? All right, I just want everybody to know that. That's funny, okay?
So this is actually what my patients see at the other end of the room. Actually, this young lad thought it was pretty funny. He says, "Hey, this is the first time I'm taller than you." So I've got my 3 exam rooms that are set up with video conferencing via iPads. And so my patients actually see me on the iPad. Yes, I'm still wearing my mask, but all of my patient discussion happens when I'm across the hall in my own separate isolated space. I'm not sharing breaths. And then I come in to do my exam. We actually do that part silently, because the less discussions and talking, the less we generate aerosols. So I do the exam silently, and then I'm back over to my electronic discussion. And so we talk a lot before and we talk a lot after, but in the room, no talking, just exam, and we're just in and out of the room relatively rapidly. So even though my patient encounter is roughly around the same time, the amount of that encounter that's sharing airspace is actually rather brief.
And Mike, with hearing about this for the first time, my thought was, my gosh, that's just got to kill your clinic efficiency. But that's not the case, is it?
No, it's actually been rather efficient. The interesting thing is that in this setting, I actually have all of the information at my fingertips. I've got so many screens available to me in my office that I can see all of the testing while I'm talking to the patients. I actually do all of my own recording now, because there's no efficient way to do this with a scribe. And I can do that while I am talking to my patients and while I am looking at my patients' faces. So I've actually eliminated a scribe and increased my efficiency. One of the things that does get lost is there's certain conversational things that just don't happen. It used to be that you'd walk into the room and you'd see somebody had a bag from some city that they visited on vacation. So, oh, I used to live near there. And that kind of stuff obviously just doesn't happen, because those little cues are lost on a video-based system. But the other thing that happens is that the discussion is all actually fairly meaningful discussion. Some of the distraction discussion that ordinarily happens just by virtue of being in a room, especially when there's 2 or 3 relatives there. Oh, by the way, as long as you're here, can I ask you about, my cousin's friend's neighbor had this eye problem? And all of that stuff is never going to be value provided in that setting, but it always creates a distraction from the issues at hand, and that stuff just doesn't happen anymore. So in fact, I'm equally as efficient, perhaps slightly more efficient by video than by being in the room for the discussion.
Jonathan, do you have any comments? What do you think about the way Mike's doing this?
I never thought I'd see a day trader of patients. It's impressive. We talked about this as we were setting up this event. It's really made me think a little bit about which are the key aspects that I need to be there for. And I think that's part of the good part of COVID. It's challenged us to really consider what are the key elements that are necessary to provide good care.
Yeah. I know, Jonathan, you've got some thoughts on kind of different visual field technology and how it applies to caring for patients in the post-COVID reality.
We were concerned early on. We were really concerned about the bulb perimetry. As we looked across the room talking about it with each other, we all basically agreed that if we had to put our head in the same bowl as a patient, mask or no mask, within 5 minutes, we wouldn't be entirely comfortable. Now, since then, we've learned more about how to clean bulb perimeters. But until we were certain about that, we got interested in a closed perimeter, the Octopus 600, which has very similar algorithms, a lot of the same algorithms of the 900, but as you see, has a closed face. And so the cleaning of this, there's no open bowl to collect aerosols. And the cleaning is just a simple wipe down from my text. And meanwhile, you can still do your G-top or full or standard threshold program. The techs really loved this because it made their lives easier and we could run at a normal flow. What we didn't expect, which was a pleasant surprise, is how much the patients like this more. The patients really prefer this. I'd say 4 to 1 patients prefer the ergonomics of this device. Not necessarily open bowl, closed bowl, but they only have the forehead rest, they have no chin rest, and ergonomically, fewer of them feel like they're being pretzeled into the machine now, even though it's on a very similar stand, identical to the old one. So that's been really a joy for our patients as well as for us, and it's allowed us to run full flow on fields essentially without changing the flow at all, which has been great.
So did you actually buy some Octopus 600s?
So we had one. We got one new one, And then we had one that we just used as a portable research. We had done some community screening projects with the CDC over the last 6 years, and we had an Octopus field machine. There was a 600 that we pressed into service for actual clinical use, which we hadn't been using it. So we got one new one, we had one old one. And so we had been running primarily 2 during the day fields for the core of our glaucoma clinic. As you know, the G-TOP program is super fast and it's super popular for patients because that it takes 2.5 minutes an eye, whether that's advanced disease or a normal field, it's always 2.5 minutes. And so these machines are super productive, and keeping that flow up is really key to taking care of our patients.
And is that a 24-degree field, or is that a 30-degree field?
Yeah, so they can do the 24-2, good point, or the 30-2. They can do either one. The only thing that they don't do that we sometimes miss is stimulus 5, which we still have the old machines, which we pull out occasionally to run a stim 5. And if you're only doing a couple a day, it's no problem. But short of that, it runs pretty much all the same, mostly all the same programs that most general ophthalmologists would want. And
And if I remember correctly, the Octopus software can display these fields and do change maps with other machines' data in the same way that the other machines present that data, and do change maps from the other machines, right?
I'm not sure which way you mean it, but we can look at essentially the 600 and 900, the data is interchangeable. We can look at old Humphrey data that we have on our patients as well. Although we can't do math, we can have it all shown up, all the grayscales in a line in a way that's very helpful. We've done studies and actually published some on the improvements in our workflow when we switched to the iSuite, looking at field progression rather than sequential fields. And it was faster even than some of the Humphrey tools, which are very good too, but are slightly different.
That's fascinating. Lauren, let's move on to the next slide. As a retina guy, I wanted to just mention another product that turns out that Haag and Reliance puts out, the IOPS tray, and how this has become central to my COVID workflow. Let's go to the next slide, please. So, COVID-19 has taught us that air is gross. We've always known that, but now we really understand that it really is really gross. Next slide. And and there's all sorts of for example, intravitreal injections. There's contamination risks that are at risk that can cause endophthalmitis, both during the injection procedure as well as prepping the drug, and that's been talked about now. And in Europe, for example, they do all injections in an OR-like setting with filtered air in what they call these IBOM rooms, and there's these mobile surgical laminar flow type things that are air handlers to help us our European colleagues do intravitreal injections. So let's go to the next slide. And there's charts that show us what kind of particles are in the air and what sizes they are. And we know that viruses can be suspended in vapor, they can be suspended in ballistic droplets, and I've got outlined here in black, where the 2 size ranges where COVID particles happen to live. Let's go to the next slide. And you can get air particle counters that will actually measure how contaminated the air is, and there are hundreds of thousands or millions or hundreds of millions or even billions of different size particles that we inhale every single day just by being human. Next slide. And if you look at different air handling clean room specifications, there's class 1 to class 9. We can mitigate those particles to a greater or lesser extent in different situations, depending on what kind of infrastructure we ramp up. Next slide. But the issue here is that other than switching to an OR purely OR clean room environment for intravitreal injections, every breath you take, it plays a real role for endophthalmitis risk. We've been talking about the silent injection when you're and the silent drug prep for a long time now. And it turns out that these same factors, when these patients come in, the same things that we do to mitigate infection, minimize talking, minimize room time with the patient, also play into decreasing COVID-19 transmission risk. Next slide. So, the steps of the intravitreal injection: topical anesthesia, iodine, open the lids somehow, inject the drug, get rid of the syringe, use a tissue, and then a saline rinse. Next slide. And typically, what we've done in the past is you've had the doctor and an assistant handing them things, and you're reaching around to the patient and then to the counter that's behind you to get to the sharps box and so on and so forth. And you've got the assistant and the physician kind of twisting and turning to do the injection in order to make that happen. Next slide. And this IOPS tray basically has, IOPS stands for in-office procedure system, has a tissue box, it has a sharps container, it has this little tray with 9 wells in it, next slide, that are all attached to an arm, that all get affixed to the floor stand pole. Next slide. And allow, and you can put into those little wells, you can put little widgets that are customizable as a function of how you want to do your intravitreal injection. Next slide. And this is what it looks like. This is, I'm not wearing a mask here because this is pre-COVID, but let's take a look and see how this goes. So I take some proparacaine out of the little tray. Now, this patient has already gotten proparacaine and betadine from the techs. This is the 3rd drop of betadine that she's getting. And you see, and it's all right there, and I'm using my left hand to brace the lids open. Then I pull the injection out. I get rid of the air, and I give the injection, and you'll see this nice lady jump a little bit, or maybe not, depending on how smooth your video is flowing. And then the syringe goes right into the sharps box. That's right there. And I can do this without an assistant in the room. And it happens really, really fast. My room time is routinely under 90 seconds, and oftentimes under 60 seconds. Next slide. And if you, let's skip this. Next slide, please.
Chris, do you want to comment about how you have the right and left eye syringes already pre-prepared and you can just flip them around?
So, no, absolutely. So if you look at the pre-COVID workflow, if you look at the pre-COVID workflow, so to answer Mike's question, those 9 wells are designed with a duplicate everything so that we can do bilateral injections using different bottles, different betadine, different saline rinses by just turning the tray 90 degrees. And if you look at the different workflows, pre-COVID-19 and pre-IOPS, and then post-COVID-19, implementing a lot of the things that Mike and Jonathan were talking about: online pre-registration, telephone check-in from your car, patient called directly to the tech room by the phone. We've actually moved testing into the exam room. We've moved OCTs into, not the exam room, into the tech room, so that the tech can do vision, tension, and the OCT right there. Then as that's happening, the scribe pulls up the chart and testing on an MD kiosk computer, much like what Mike's setup is. And then the doc I'll review the chart, and I'll review the do a timeout and all that sort of a thing, and review the scans and do 90% of the medical decision making without the patient even in the room. Then the patient gets brought back from the tech room to the MD room by the technician, gets the third hit of betadine and topical, and then I enter the room without a scribe, and give the injection and check the patient out by telephone usually. So let's go to the next slide. So the key thing here is the IOPS tray, in addition to all the other COVID workflow implementations, took us from 7 person-to-person interactions down to 2 person-to-person interactions. What took the patient from 3 waiting room stays to no waiting room stays. And, and obviously from a longer building dwell time to a shorter building dwell time, and from a less than 90-second patient scribe MD room, patient MD room time. I'm sorry, that's wrong. A greater than 7-minute patient MD room time to a less than 90-second patient MD room time without a scribe. So, does this make a difference? Who knows? I think it does. And this is our form of the universal precautions.
And I think that's really great. I just want to make a comment that the beautiful thing about what you've done is whether or not it makes a difference for COVID, it also makes a better patient experience. And that's the wonderful thing that seems to come out of a lot of these COVID. Patients don't really want to spend time with my fish out in the waiting room.
Yeah, there's no doubt about it. So that, and we've got, we've designated injection only clinics now. And do our clinics still run behind? Yeah, because sometimes the pathology load just is not compatible with running an efficient clinic. You can't control for all the factors that can blow up your clinic. But the really interesting thing about is that we're much more efficient, and the patients love it. They're in and out in under 45 minutes now, which has not been the case in the past. So Lauren, let's go to the next slide. And actually, I think and let's go to the last slide now. That's just another video. We can skip that. And let's hide that, because we're done with the slides. And let's just have our panel talk a little bit about a few more things. So with 2020 hindsight, I would like to ask Mike and Jonathan whether or not the shutdowns and the suspension of outpatient elective surgery was justified. Acknowledging the striking regional differences in COVID fact patterns around the country, Mike, one of the reasons to shut down the way we did and were PPE shortages. This concern certainly applies to ophthalmology. Do you think the initial shutdowns were justified?
I think at the time that we did them, I think that was the right thing to do. Even now, our knowledge has certainly grown markedly about how this virus is transmitted. What we knew in the middle of March was minuscule, and everything that we feared at the middle of March is kind of the curves that we're seeing now that the weather's getting crappy. And we didn't know what measures we could do to mitigate. We didn't have adequate PPE inventories, and the concerns were not only overwhelming the medical systems at the hospitals. We actually, you'll remember, Chris, that we had discussions at our board level of, do we need to be prepared to convert our surgery center into an overflow COVID ward? Yep. Now, those discussions seem very distant right now, but it wouldn't surprise me greatly if we started having those discussions in the next week or two. Ohio now is having roughly 8,000 cases a day. Again, just like Jonathan mentioned, about 7 to 8-fold what it was just a couple of weeks ago. And we don't know where that's going to peak out. I'm delighted that vaccine is going to be available, but that's not going to happen instantaneously. It's going to have to get about 4 or 5 billion people before it has a huge global effect. So these are all issues which we were facing in March with very limited knowledge and very limited supply chains. Now we're facing them again, and we're starting to see states have greater restrictions. As Jonathan mentioned, New Jersey's talking about shutting down ASCs again. And some of these same issues are still existing now, but we're facing them with more of a knowledge base. But I don't think we have a full knowledge base. I don't think anybody knows what this is going to be like in a month. Maybe it's going to taper off and it's going to reach a peak, and then people will start being a little bit more careful again. I'm sure all of you have heard about various settings where things didn't work out so well. I just heard today from one of my surgery techs that her daughter's class, somebody in the class, their parents thought it was a great idea to throw a 100-person Halloween party for the kids. And it ultimately ended up in the isolation of nearly 700 kids. So there's all kinds of not so smart maneuvers that are going to happen out in society. They're going to thwart all of our best plans within our practices and operating rooms. So I'm not sure where we're going right now. Do I think it was smart to shut down when we shut down with the fact patterns that we had and the data that we had? Yeah.
I agree. Jonathan, Wills is a hospital, a freestanding eye hospital. What did you guys do for, were there discussions about tapping into your vast resources to take COVID patients and use your operating rooms as ICUs?
Right, indeed. So we work with Jefferson University Hospital, and we made we have 4 inpatient beds, 3 overflow beds, and 8 ORs. And so we have actually a fair amount of equipment and space, and we made them available. But in Philadelphia, first round, we peaked just below the overflow. It was just that capacity, never quite became necessary. And I share Michael's concerns that we really don't know what's going to happen in the next month or two, and whether that's going to be necessary. So there are a lot of different factors about shutdowns, and one of them is really not just about whether we're doing the right thing, but also about whether our resources are needed or whether we're contributing to a larger issue. So it's complicated. Also, I want to say that I think the shutdowns have really negative ramifications, but sometimes to get the message across to the public, the non-MD public, it's hard for them to understand the seriousness, and the shutdowns do help with that, although it creates a backlash, and we won't get into the politics. So,
well, so I think that the one of the most important aspects of the shutdown is, a lot of our clinics, historically, you're drinking from a fire hose, and there's really, and you're just trying to keep up, and you're trying to prevent that mutiny in the waiting room. That is so often just a few patients away. If you just run a little bit later, then the mutiny happens. And what it did is it let us all kind of stop and think creatively and adapt. And the interesting thing, and I think that there is a little bit of hopefulness here. Again, data. The Cincinnati Eye Institute and its parent organization have 1,350 employees. And so far, knock on wood, maybe I shouldn't say this, there hasn't been a single documented case of workplace transmission of COVID in the setting of 42,000 patient encounters every month, patient interactions. And we bounce back within a very short period of time. So since July, we've been running at full tilt. And I think that it's hopeful. I think it's hopeful that we can hopefully do it and maintain our new workflows and prevent ourselves from becoming super spreaders. Is anyone aware of any ophthalmologists or ophthalmology clinics being identified as super spreader locations?
Chris, I don't know that we have enough information to know that, because the way that the trackings are done are occurring at the Department of Public Health, and until just this past week, CEI was kind of, and CVP have been deferring to the Department of Public Health to do that tracking. So we're not 100% sure what transmissions have or haven't occurred within our building because we don't have that data. And the only way that we would be able to isolate that data is if we were told by our county Department of Public Health that it occurred and whether they were actually applying tools to seek out that information. So, I think that part of the story is we don't know. We actually, as an organization, have had some staff members who have become COVID positive. We have had some physicians who have become COVID positive. And if you do the math, it's actually not a whole lot different than the general population in our region. So while I'd love to say that I think we're doing better than the general population in our region, I think we're doing about the same.
Which, to be fair, doing about the same while seeing lots and lots of contacts each day still means you guys are doing the best job you can. And I would say that your comments are very welcome about not knowing about certain types of super spreader. What we've partly looked for is a pattern where like 2 people in the same clinic got COVID at the same time, something like that. And so I think we have a little evidence that we've not been catastrophic, but still you're quite right. The Department of Public Health would know better.
Yep. And you know, from the standpoint of the shutdown, there are some, as we alluded to, there's healthcare costs related to the shutdown. You know, Wills has been at the forefront of publishing data showing a substantially increased percentage of patients presenting with macula involving more advanced retinal detachments and primary retinal detachments that already have PVR on presentation, presumably due to COVID-related delays in presentation, diagnosis, and care. There's similar data that's recently been published in, and I think, Retina Times that showed a several letter worsening of presenting visual acuity in new wet age-related macular degeneration patients since the COVID epidemic. There's data out of Duke that clearly shows that this fear of COVID has delayed patients seeking care for heart attacks and strokes. And there's probably been some, and they suggest a significant increase of morbidity and mortality from this either real lack of access to care or perceived access limitation of access to care. You know, Mike, have you seen a change in the pathology mix in your patients? Have you seen more advanced disease come in at all, or a lower willingness for people to travel to see you?
No, actually, I haven't seen that, but again, I've got a very skewed practice. It's not a cross-sectional practice. The disease pathology in my practice is usually pretty significant, and dangling implant lenses and marfanoid lenses that are hiding up underneath the limbus. That's just kind of the bread and butter of what I see. So a lot of those things don't and can't wait. One of the interesting questions, though, that I'm curious about, and we all know people who decided to close up their practices in March when everybody was closing down for partial shutdowns. And I'm sure we all know, I know at least a few people who said, you know what, I'm done. I'm done. I'm not going to go through the pain of reopening and the cost of reopening. And I decided I'm just done. And I don't want to take the risks of exposure. So I know at least a few people who have exited themselves prematurely from the provider role. And so I wonder whether some of the challenges that we're seeing now with later stage disease presenting might be limited due to access, since we know that ophthalmology is now in a demographic situation where there's a relative shortage of providers, especially for some of the more severe disease. And I wonder whether this has exacerbated that in some ways, not just by having partial closures, but by having some people who said, you know what, I'm leaving the provider workforce.
I think you're right, exactly right. I think the provider to the physician to pathology ratio has been trending in a problematic way for a decade now as the baby boomers turn 65 and get age-related eye diseases, and that's been exacerbated by COVID. What have you seen in the Philly area?
Yeah, very much the same things, and that's a really important point about the retirement of physicians. And also, to be fair, that many of us, having experienced a normal work week, are reconsidering the work weeks we've had. There's already a study about a year and a half ago showing that America in the next 10, 15 years is expecting about 100,000 person shortage of surgeons and specialists, physicians in general. And so this will exacerbate those trends. So the good news for the younger physicians is there's going to be plenty of work to be done, but who will take care of old timers like us when we retire in the next 10 years? I think there are going to be some challenges.
No, I agree.
Chris, if I may, I'm going to just jump in. We're getting here to the top of the hour. Just a quick time check. Yep.
No, that's great. That's fantastic. So let's mention some concluding thoughts. You know, I think that we can conclude is that ophthalmology and routine eye care, in quotes, you know, is not elective or are not elective, but rather essential in many instances. And delays in care can have serious long-term and irreversible consequences that have to be rationally balanced against the risk of COVID morbidity and mortality by each doc and by each patient. As somebody who takes care of, you know, my joke is 50% of my patients are diabetics. The second 50% of my patients are age-related macular degeneration, and the third 50% of my patients are everything else. And I think that we have. I'm very, very sensitive about turning into a super spreader and hurting my old, frail, and vulnerable patients. On the one hand. On the other hand, I think we can suggest that our novel workflow adaptations and hardware-based COVID adaptation strategies have so far, knock on wood, been successful and can allow us to continue to work safely and care for our patients in the setting of the COVID-19 epidemic. Ophthalmology is a frontline specialty, and a lot of the work that we do is essential to our patients, their families, and society at large. Jonathan, final thoughts?
Well, I just want to sort of echo something you had said a few minutes ago, that for me, the pandemic's been a real kick in the pants to innovate, to provide care safer, faster, and better. And I think it's allowed us to challenge established paradigms and improve the care we give in every way in terms of safety, quality, and the patient experience. So unfortunately, this worsening wave in Philadelphia is going to give me a second chance to maybe do better. But maybe that's the silver lining.
I agree. Mike, final thoughts?
I totally agree. I think there's lots of changes that we've made that we are going to keep because they're better, they're more efficient. I don't think any of my patients are going to say, boy, I really missed the days when I was stuck there for 3, 4, 5 hours. We're just not going to hear that.
No, I agree. Garrett, I think that pretty much takes us to the end of what we wanted to talk about. We're happy to field any questions from the audience. Looks like there's 60 people on, and happy to take any Q&A.
Yeah, go ahead, Lauren. Are you seeing some of the questions? Yeah.
Yes, we did receive one question. What does Cincinnati Eye do when an employee reports an exposure to COVID or worse, test positive?
So Mike, you want to take it or I can take it?
Sure, I'll go ahead and take it. So, this has actually occurred. We've got a lot of people in the organization, so this has occurred. And basically, CEI has been following the paradigm set out for the CDC for essential healthcare workers. People who are positive are asked to stay out, isolating depending on whether and when they got symptoms. And as I'm sure all of you know, there's a metric that the CDC has posted on that. One of the real questions, and in my mind, and again, I'm much more risk averse than most, is should we consider our tech members as being essential healthcare workers for the purposes of what the CDC recommendations were designed? It is my personal opinion that the CDC recommendations were designed to allow people who were managing COVID positive people in the hospital to continue doing their work. Otherwise, every single member of that ward would have to, work one day, take 24 off, which would of course be ridiculous. But I think that in a setting where we're not supposed to be having COVID exposures on a regular basis, I think we're more of a general population. And so it's a question that I lean again much on the much more conservative range of things. Should our employees be considered members of the general population, or should they be considered essential healthcare workers? And are all of the employees the same? Are some of them more essential than others in this setting? Quite frankly, I don't think in that definition that I'm always an essential healthcare worker. There's very few settings where I can't imagine that whatever I have on my plate for 10 days, that one of my partners couldn't cover for me for the stuff that couldn't wait a week and a half. So it becomes a question of, should we have other tiers? And I don't know the answer to that. The CDC has unfortunately not been able to provide a whole lot of guidance in this whole mess, and their record has not been great. So I'm not sure what the right answers are.
So I agree with you, Mike. I think that from my understanding of our policy, because we recently had a retinal surgeon test positive. So anyone that, we follow the CDC guidelines to the letter, and that doc gets to come back when he's more than 24 hours symptom free, at least 10 days after his test or her test. And I guess, and then anyone that was a close contact, so 15 minutes of exposure within 6 feet, quarantines for 14 days. A big thing that a lot of people ask questions about is, well, is a contact of a contact a contact? And the answer is the CDC defines it as not. So Mike, if you've got COVID and I've been around you, then I have to quarantine, but my kids can still go to school. Unless I get sick and or test positive, in which case then they start quarantining. So a contact of a contact is not a contact. Jonathan, what about at Will's?
Yeah, we're along the same guidelines. And I'd say a big emphasis at the workplace is that everyone maintains proper PPE at all times. Because if everyone is masked, then it's very hard to have an exposure. So if I'm masked and you're masked and I'm positive, my contact with you is not an exposure. And that's really critical. But we've run into challenges, thanks to the glory of Facebook, where we see our employees having wonderful parties on the weekend sometimes. And that's where these exposures can come from. And look, everyone's got to blow off steam. It's hard. It's been a lot of months, but I think that's a challenge going into the winter. We're trying to meet to minimize the possibility of actually having a contact.
I think you bring up a very good point about compliance, both within the organization and without. I can tell you, rarely does a day go by where I don't see somebody in the building with a mask down. I'd love to say that it's 100% compliance. It isn't. And it's not going to be. It's, people are people, 1,300 people, it's just not going to happen.
But I think we all have to be comfortable in protecting each other by reminding each other, I think your mask slipped down, I want to keep you safe.
Yeah. Well, with that
Point.
I want to thank Jonathan and Mike for a really great discussion tonight, and I wanted to thank Garrett and Lauren for moderating and handling the technical aspects of all of this, and our friends at JobsOn for partnering with us to make this presentation possible. Garrett, any final and of course we want to thank Haag-Streit for sponsoring this and making it possible for everyone. Haag-Streit Reliance. Garrett, any last thoughts from you?
No, I want to thank you guys for conducting this chat with everyone tonight and with your peers. I think it was really compelling. It certainly is some unique circumstances that we're all having to adapt to. And I think you've presented some great ideas tonight on how at your facilities you've already done that. So for our audience, if anyone have additional questions, Lauren, are we able to allow them to unmute and ask questions live as well as the chat, or give us some direction here? If we have any additional questions, I thought we'd give that a moment.
Yes, if anybody has additional questions, you can raise your hand and I can unmute you if you prefer to ask the question live.
And how do you raise your hand in this session? Maybe that would be helpful for those that may be a little technically challenged.
Let's see here. Well, if you have a live question, if you want to just enter, say you want to ask the question in the Q&A box or the chat
Okay.
box, that will
Yeah.
probably be easier.
Yeah. Do you see any others? Do you have any others, Lauren? No. Okay. Okay, great. So with that, I think it's been a great evening. I know it's late in the East and in the Midwest, so I want to thank everybody for your participation. Thank our esteemed panelists for joining and sharing your perspectives tonight. Very compelling. Thanks and have a good night, everybody.
Good night, everyone. Thanks for logging on.
You bet.